Hello everyone, welcome to day 7 of our Challenger series. Today we will be completing the rest of the psychiatry which was supposed to be completed. Just go through your notes quickly and we will complete this session in 20-25 minutes. Starting with schizophrenia spectrum disorders. The important things you need to remember in schizophrenia is the presence of all positive, negative and cognitive symptoms and the 12 Schneiderian first time symptoms. You need to remember diagnosis requires greater than 2 of the following active symptoms. The greater than 2 of the 5 things which you need to remember are delusions, hallucinations, disorganized speech or disorganized behavior, which is catatonia also included under this, and there is negative behavior, negative symptoms. So greater than 2 of these active symptoms should be present, and greater than 1 among all disorganized speech, hallucination and delusion should be present. So I have already told about timelines yesterday. I will not be speaking much about timelines today. Schizophrenia, the timeline of psychotic disorders was not discussed. So just remember, for schizophrenia it's 6 months. You have symptom onset before diagnosing that, and greater than 1 month of them should have active symptoms. So in the past 6 months, you should have at least 1 month of active symptoms, and you should have at least greater than 6 months since the person has started having symptoms, with in between phases where he might or might not have symptoms. That's all you need to remember. And then there is some important pharmacology related topics related to schizophrenia, which we'll be discussing later. Next is the other psychotic disorders which you need to remember. Among them, you need to remember schizophreniform disorder. All criteria are met, but duration is between 1 to 6 months. Just remember this important thing. Active symptoms should be for greater or of 1 to 6 months, since the person has started getting all this delusion, hallucination, disorganized speech and other stuff. If he has crossed that, then he will be schizophrenic. Next, you have brief psychotic disorders where the duration is less than 1 month of positive active symptoms. Then you have schizoaffective disorder. So here you can see that the name itself tells it has both schizo and affective symptoms that affect, which I have told, mood and affect. So affect is also being described, and schizophrenic thing is also being described. So the person has schizophrenia plus mania under affect. So this should be 2 weeks of symptoms without any manic or depressive episode. Okay, 2 weeks of psychotic symptoms. If it has manic or depressive episode, you will directly go into your mood related disorders. Okay, then you have delusional disorder where one delusion has been there for the last 1 month at least, and no other mood or psychotic disorder has been there documented. Then you have your schizotypal personality disorder, which comes under cluster A personality, which I'll be talking later. Here the person does not have any psychotic symptoms, but he is odd or eccentric behavior. That's all from psychotic things. Next we'll move to mood and related disorders. The most important thing among them being the type of mood, that is the quality. If he has excessive symptoms or the reduced symptoms. So depending on that, he will be classified into mania or hypomania, or euthymia, where the normal person is described as euthemic, and then you have dysthymia or depression. Okay, just remember the important cycle which I have given in the book. Along with that, mood related disorders, you need to remember mania. In mania, the most important mnemonic is your DICFAST, which is distractibility, impulsivity, grandiosity, flight of ideas, goal directed activity, A for activity or your agitation. Then you have sleep, decreased need of sleep, and last one, talkativeness. So this is all important things to diagnose mania, and the timeline is again for 1 week. You have some drugs which I will be talking later. Then for hypomania, you should have the same symptoms as manic episode without any psychotic features. One important thing to remember in hypomania is the person does not go into the complete state of mania. So the elevated things will be there, but not to the extent of mania. Other than that, what you need to remember is there is no functional impairment. That is the most important thing. In manic symptoms, you should have at least three of this. However, along with functional impairment, in hypomania there is no functional impairment. That is why it is having a separate diagnosis. Then you have your bipolar 1 and bipolar 2, with bipolar 1 timeline being greater than 4 days of symptoms, having one manic episode and or hypomanic episode plus depressive episode. Then you have your bipolar 2, where both hypomanic and depressive episode must be there without any manic episode. So just remember, bipolar 1, mania should be there, plus hypomania or depression. Bipolar 2, hypomania plus depression will be there, no mania. So this will come like this and this will come here. That is one important thing you need to remember. Mood will be stable in between the episodes in bipolar 2, and the person has increased risk of suicide. Then you will go to other important things, cyclothymia, where the person has greater than one hypomanic and depressive episode. It is a milder form of bipolar disease, where the symptoms will be present for a long duration, greater than 2 years, present for at least half of the time, and there is no remission longer than 2 months. That's important thing you need to remember. Bipolar 1, bipolar 2 and cyclothymia you need to treat with cognitive behavioral therapy along with antidepressants. In hypomania, you need to treat with antidepressants and antipsychotics. For mania, you need to treat it mood stabilizers and typical antipsychotics. Then you have depression related things, where is the famous mnemonic size caps comes, where you have sleep disturbances, decreased interest, I for interest, then guilt, G for guilt, increased guilt, then you have decreased energy, decreased concentration, increased appetite, increased psychomotor retardation or agitation, and increased suicidal ideation. So anything greater than 2 weeks, you'll classify it as major depressive disorder. If it has 2 weeks of this along with psychotic features, then it will be MDD with psychotic features. The treatment significantly changes, where MDD you will treat with CBT and SSRIs, while MDD with psychotic disorders you will treat with antidepressants along with antipsychotics or ECT. Then you have persistent depressive disorder, which is also known as dysthymia, for greater than 2 years the patient has. This is an analog for your mania having cyclothymia. So that is also present for greater than 2 weeks and 2 years, and this is also present for 2 years. Then you have MDD with seasonal pattern, which usually associated with late fall or winter, associated with atypical symptoms like latent paralysis, hyperphagia and hypersomnia. These are important things, atypical features of depression. This was asked as a PYQ. You have latent paralysis, then you have your hyperphagia, increased need to eat and increased sleep. Okay, you also treat this with same, and along with that you have light therapy for this. Then there is other important classification called depression with atypical features, where the same atypical symptoms should be there, and this is not seasonal. Here you treat it with CBT and SSRIs and also MAO inhibitors. Then you have other important things like postpartum psychotics and postpartum blue and MDD with peripartum onset, which come under pregnancy and related disorders. In postpartum blue, which appears to be normal because it begins 2 to 3 days postpartum and resolves by day 10, it is self-limiting and you just have to give supportive therapy. There is suicidal ideation won't be present in postpartum blue. However, MDD with peripartum onset, suicidal ideation might be present. However, postpartum psychosis, as the name itself suggests, suicidal thoughts will definitely be present. This happens within 2 weeks postpartum. MDD with peripartum onset begins within the first month. However, it lasts for greater than 2 weeks and it meets criteria for MDD. So the treatment for MDD with peripartum onset is CBT and SSRIs. However, postpartum psychosis, as the name suggests, needs to be treated with antipsychotics and ECT. And then I have given you the diagram of Otto-Baragat fold, which is an important thing in depression. Along with that, ECT, one or two important things you need to remember in ECT is we induce tonic-clonic seizures. Before that, we'll give pre-medication with atropine or glycopyrrolate. And there is dose and all, which is not important. The important thing is its used in refractory depression with psychotic symptoms, catatonia, and suicidality, having acute emergency situations. There is no absolute contraindications as such, and it is also safe in pregnancies and older adults. Some important side effects also you need to remember, among which is your retrograde amnesia. And next we'll move on to anxiety and related disorders. Just remember 5 important things: panic disorder, GAD, agoraphobia, social anxiety disorder, and specific phobia. I'll not talk about the timeline. Panic disorder should have at least one panic attack with some important features. Then generalized anxiety will have excessive worry about daily life and most days. Agoraphobia, as the name suggests, is your fear of extremely open or closed space due to inability to flee. There are other phobias you need to remember. Just go through that list. Along with that, you have your social anxiety disorder, where there is fear of social embarrassment, and specific phobias, which I have already told you need to remember: spiders, heights, and other stuff. Spiders is your arachnophobia. Then the timeline for most of this is 6 months, except for panic disorder, where the timeline is for 1 month, and the treatment of most of them will be CBT and SSRI. Next important thing is to remember dissociative disorders. You just need to remember some important things in dissociative disorders: depersonalization, dissociative amnesia, dissociative fugue, and dissociative identity disorders, where in a depersonalization, derealization disorder, the person does not have any effect. It will be flattened, and the person will have dream-like experiences or automation. So he feels out of the world. He does not feel anything is real. However, in dissociative amnesia, the person is having profound loss of memory for personal history and amnesia for personal identity. Next, for dissociative fugue, the patient has unplanned traveling or wandering, inability to recall past events, and loss of memory of identity. This might seem like schizophrenia only. So other than that, your dissociative identity disorder, your famous movie related stuff, all your Bhul Bhulaiya kind of stuff, which is your problems with daily function, along with gaps in memories, where there will be presence of 2 or more distinct personalities at the same time. Next important thing I have skipped is your trauma and related stuff. In trauma and related stuff, you just remember PTSD. There's also acute stress disorder and adjustment disorder. For PTSD, you just remember the person will have history of sexual abuse or witnessing a death or something like that, a trauma, where the person will keep on having flashbacks of that, and will have sleep disturbances and nightmares. Okay. Diagnosis is that symptoms must last for greater than 1 month. So treating again is with CBTs. Okay. Then you have your next important thing, which is malingering, factitious, and somatic disorders. This is not expected as much as others. You just remember one important thing: Munchausen syndrome and Munchausen syndrome by proxy. In Munchausen syndrome, the person imposes the disorder on himself and will try to undergo invasive procedures and tests. However, in Munchausen syndrome by proxy, the person condition is caused by caregiver who inflicts symptoms on another person, usually children. Okay, it's a form of abuse. That is why it's called as proxy. Then there is one table for malingering versus factitious disorder versus somatic symptom disorders, which you can go through. Then you have your OCD and related disorders. For OCD, you remember that it should have intrusive thoughts, which is obsession, followed by repetitive action, which is compulsion. It is ego dystonic, and there is strong association with your Tourette syndrome. your Rani Mukherjee's Hitchki movie, which is your tics, which have produced sounds, vocal tics. Okay, other than that, there is also association with body dysmorphic disorder. So, next important thing you need to remember is the trichotillomania, which I have described in a beautiful image also. Then there's one more thing called body dysmorphic disorder, where the person is preoccupied with minor or defects which are not even present in himself, which causes emotional distress and repetitive appearance related disorders like mirror checking and other. It's also common in people who have eating disorders, especially anorexia nervosa. Then you have your excoriation, where the person keeps on picking skins, hoarding disorder, where the person will keep on collecting things that are of no monetary value, like collecting newspapers for 10 years or something like that. Then you have olfactory reflux syndrome, where the person thinks that he is emitting foul smell from the body. This is exactly in contrast to your merciful anosmia in ENT. So just remember these two steps. Then you have personality disorders, clusters A, B, and C. In cluster A, we have your SSPs, schizotypal, and paranoid. Schizoid is like almost like the person lacks interest in relationships and has little emotional expression, while schizotypal, the person does not have any hallucination as such to differentiate it from psychotic disorder, and the person is superstitious with odd beliefs. Paranoid is more like your psychotic disorders, where there's distrust of others and suspicious for everything. It's a ego defensive mechanism. Then for cluster B, you have your ABHP, which is antisocial, borderline, histrionic, and narcissistic. One important thing you need to remember is your histrionic, which is drama queen or dramatic behavior. Narcissistic has your grandiosity and always wants the envious of others, responds badly when criticized and other stuff. Borderline, you need to remember one important thing, which is dialectical behavioral therapy, and it is also ego defensive mechanism, which is splitting. Then you have your antisocial, where there is lack of empathy for others. Then for cluster C, you have your AOD, which is avoidant, obsessive compulsive disorder, and dependent personality. That's all from cluster disorders. Then you will need to remember about eating disorders: anorexia nervosa, bulimia nervosa, binge eating disorder, and pica. Among that, you just need to remember anorexia nervosa. The person does have intense fear of weight gain. BMI will always be less than 18.4. Bulimia nervosa, the person binges, eats for something, and then he himself wants to purge. That is, he will cleanse himself by putting his fingers under his throat and trying to vomit. These symptoms will be present for greater than 1 week. The person will have normal or sometimes high BMI. Between greater than 18.5, sometimes it might cross greater than 25 also. The important thing is there is because of repetitive vomiting, there is electrolyte disturbances here. Then in binge eating disorder, the person keeps on binging for at least 1 week for greater than 3 months. This is associated with weight gain and diabetes. Pica is associated with your iron deficiency anemia and other stuff. There will also be intellectual disability in such patients, where the episodes last for greater than 1 month. Then we have your gender dysphoria related things which you can go through, and then you have other sexual related conditions, transgender, transvestism, and other things. Next important thing will be your mental retardation, or the new name under childhood and early onset disorders, intellectual disability. So among this, you need to remember specific learning disorder will last for greater than 6 months and will have inability to learn a specific school subject. ADHD, the person will have onset under 12-year-old child, and for a period of greater than 6 months will have hyperactivity, impulsivity, and attention. It's more common in boys. And there are other comorbid conditions you need to remember. The treatment for ADHD is very important. You need to remember stimulants, which is methylphenidate, CBT, and alpha agonists, which is clonidine and guanfacine. We also use atomoxetine for treatment. For Tourette syndrome, the person is having intractable tics, then you need to give tetrabenazine or antipsychotics. Then you have your intellectual disabilities stuff, which is mainly supportive therapy. And for autism spectrum disorder, there is one important memory trick you need to remember. If the person has normal IQ, sometimes they might have high IQ. The important thing to remember is Asperger's, the language abnormalities and regression of motor symptoms or other developmental regression is there. Then it has to be either Rett's, which is excellent, is especially exclusively present in females, and there is association with MECP2 gene, and Keller's, where the age will be slightly more greater than 2 to 3 years. Male and female both are equally affected. Next, you have to remember regression of milestones. If it is absent, then it will come under autism. Other than that, you have your childhood behavior and anxiety disorder. Among these, you just remember everything. The important thing you need to remember is your oppositional defiant disorder. That is one thing. And conduct disorder, both of them will have timeline of greater than 6 months. Conduct disorder, if it is persistent after age 18, then it comes under your antisocial personality disorder. Then you have sleep disorders. You can go through them. The important mnemonic for sleep disorders, the sequence of your EEG waves: B, bats drink blood; beta, alpha, theta. Then with S, you have your spindle complexes. Then with D, you have your delta, and again beta. So this important mnemonic you need to remember. And amongst that, this B is your awake state, and this B again is your REM sleep. Rest of them will have, there is A will have your resting state or meditation, then you have your sleeps and REMs like cycles. Okay, just remember this and some important associations for them. Among them, there was one POIQ also on hypnogram. What is hypnogram? And then you need to remember some conditions associated with that, especially nightmare versus night terror, and also your narcolepsy and treatment for all of this. Then psychopharmacology, just remember typical versus atypical psychotics. How do you remember them? Typical is your haloperidol, flufenazine, trifluoperazine, thioridazine, chlorpromazine or pimozides. So all your zines come under typical antipsychotics, ZINEs. Don't confuse it with clozapine, all your penes. Okay, penes and ONS come under typical. Typical important thing will be the presence of HAM side effects, which is antihistaminic side effects, anticholinergic side effects, and muscarinic side effects. Sorry, histaminic side effects, anticholinergic side effects, and your muscarinic side effects. Also, there is hyperprolactemia. For atypical, you need to remember your metabolic syndrome, especially with your pains. Highest is with other important things you need to remember under atypical, like each important drug. One important thing you need to remember for clozapine will be your maximum weight gain and wet pillow syndrome. And for thioridazine, you need to remember increased QT interval and retinal pigmentation. Clozapine is also associated with granulocytosis, so they'll give a clinical scenario where you need to monitor WBC when the person is on long-term clozapine. There are other important side effects also you need to remember that we have already mentioned separately. Then there is your extrapyramidal side effects associated with antipsychotics, and there is the famous rule of 4 where the onset of symptoms. So this is your DAPT. No. So the person is not adapting. So it is DAPT. No. The important rule of 4 starts with 4 hours, 4 days, 4 weeks, and 4 months for these 4. So what is happening here is dystonia, akathisia, Parkinsonism, and tardive dyskinesia. With N and O is your neuroleptic malignant syndrome and your oculogyric crisis. Treatment and all has been mentioned there. Go through them, and then you have your next important thing, which is your antidepressants. There again you have your typical versus atypical. So typical will have action through your increasing serotonin, increasing 5-HT. Atypical act by other mechanism. Typical, the important thing you need to remember is the classification. They are reuptake inhibitors. They have serotonin and NA reuptake inhibitors or selective serotonin reuptake inhibitors. Non-selective will have your TCA and SNRIs. Selective will have your SSRIs. So important symptoms for TCA will be your ACH inhibiting symptoms, alpha inhibiting symptoms, histamine antihistaminergic symptoms, and your famous SAM mnemonic, which is seizures, arrhythmia, and metabolic acidosis. For SNRI, it has again hypertension plus SAM symptoms. For SSRIs, there is important thing related to sexual thing, which is delayed ejaculation or anorgasmia, and then there is discontinuation syndrome also. Important side effects or the facts for each of the drug has been mentioned. One important thing you need to remember is two questions, which is drug of choice. In acute mania, it will always be lithium along with antipsychotics. And for prophylaxis in BPD, rapid cycler, valproate is used. Only BPD, lithium is used. BPD in pregnancy, antipsychotics, olanzapine and quetiapine are used. Avoid lithium because of its teratogenic side effects. Avoid valproate also. Mood stabilizer for prophylaxis of suicide in BPD is your antipsychotic clozapine. Then I mentioned a bit or two about lithium. Let's go through that. Then that's all from psychiatry. Next we'll be doing a video on your orthopedics. We'll also complete orthopedics in 2 sessions. Just like that, we in no time we have completed 115 pages from our notes, and I think at least you have got 15 to 20 questions in your pocket by these revising these subjects for the next 2 exams, that is INI and NEET 2025. All the best, keep revising. Let's complete this very soon.